Okay, so we're slowly getting there. We're on our transition now. So we've talked about the heart, and we've talked about the vessels, and we've talked about how the kidney affects blood pressure. Where we're on our way to right now is understanding how the kidney works. Okay, so before we can really get to understanding how the kidney works, we have to talk a little bit about fluids in the body, right? And where they are, how they move, how they change. So our fluid balance, our fluid intake versus output, all right, is represented in this table here. So in a typical person, we ingest about 2.1 liters, and we create about 200 liters, or not 200 liters, 200 mLs, that's not liters, that's mLs, from metabolism. So what the heck does that mean? You have to remember, back when you learned the Krebs cycle, that one of the outcomes of the Krebs cycle is water molecules, right? You take carbohydrate and you produce CO2 and water. So it means that we actually produce water in our metabolism. We extract it, so to speak, from the carbohydrates that we eat. So our intake is, around 2.3. Now, hugely variable, all right? It depends on how much water you drink, how active you are, all that kind of stuff. The numbers are not important here, okay? It's the relative relationships between them that is. Now, what about output? Well, we have some measurable outputs, right? So we can measure urine. We can, if we try hard enough, measure feces, although it's harder. Sweat, we can sort of measure, but that's pretty difficult. We also have a fair bit of loss through the skin and through the lungs. We call those the insensible losses. I would add sweat to the insensibles because you can't really measure sweat effectively, at least not in the hospital. So what we mean by insensible is, and some of you have worked at the bedside, so you know about ins and outs. One of the things we measure in patients who are in the hospital is we measure how much fluid they take in, and then we measure how much fluid they put out, right? And if you look at that, they never balance. There's always more in than out because we cannot measure all of the outs, all right? And these insensible losses in the skin and lungs, they vary, okay? So like, if you have a fever, for example, you lose more water through your skin and lungs than you do when you're afebrile. If you're exercising, your lung loss goes way up, right? Now, why do we lose fluid through the lungs? Evaporation, right? You're taking air and you're putting it in really wet bubbles. So when you exhale, some of that wet goes right back out with it. In a few months, we'll be able to see our breath outside. That's insensible lung losses. Now, we actually use this for cooling, okay? We've all seen our dogs or even our cats pant. They're panting to increase their lung evaporation. It works like a swamp cooler, right? It cools their blood as that evaporation occurs. Now, if we look at the exercise column, we'll see that our insensible losses in the lungs go way up. Sweat loss can go way, way up, right? Yes, you can produce 5 liters of sweat when you're exercising. Try not to think about it, right? And when you're exercising, your urine output actually goes down. But in general, if we look at a patient over days, their input and their output should approximately equal. Now, if we can't measure all the outputs, how do we assess that in a patient? We put them on a scale, right? Because water has weight. So one of the things we'll do with patients in the hospital is daily weights, and it helps us to assess their fluid status. You're not going to gain a kilo overnight from eating things, right? You're going to gain a kilo overnight because you have an extra liter of fluid on board, okay? So a little bit about intake and output. We're going to talk about a few different fluid compartments in the body, all right? Plasma is really what we've been talking about so far. That's circulating blood volume, all right? Plasma is, it's about 3 liters in the human. And interestingly, it's through the plasma that we put things in and take things out, right? So like urine comes from the plasma. When we drink water, that ends up in the plasma, right? So our ins and outs are through the plasma. On the other side of the capillary membrane from the plasma is the interstitial fluid, okay? And then on the other side of the cell membranes from the interstitial fluid is the intracellular fluid. So you'll see that most of the fluid in our body is intracellular. The plasma is the circulating volume, and it's actually relatively small. You know, if you do the math, 28 plus 11 is what, 39? So less than 10% of our fluid is circulating, all right? And this plays a role in how we manage patients. You know, for example, if we want to affect the potassium level of a patient, almost all that potassium is intracellular, right? So we have to do some tricks in order to get the potassium into the plasma where we can do something with it, either make it higher or lower. Now, all of these compartments, interstitial fluid, intracellular fluid, and plasma, they're in constant exchange with one another, okay? So across the capillary and across the cell membrane. So changes to one compartment are reflected in the other compartments, typically, all right? So we will talk a little bit about moving things from intracellular to extracellular fluid probably tomorrow at this point. If we look at what's found in the plasma versus what's found in the intracellular space, we see some pretty significant differences. This should look familiar because we looked at a table very similar to this when we talked about membrane potential, okay? You know, a lot of sodium outside, a lot of potassium inside, a lot of chloride inside, a lot of other anions on the inside of cells, right? Chloride is mostly extracellular. Bicarb is mostly extracellular. So I say, what is intracellular and negative? What I'm getting at is protein, all right? Protein is the primary anion inside of cells. And that can matter because, remember, proteins have a pretty hard time getting out of cells. So they're kind of stuck in there, which is probably why our membrane potential tends to work the way that it does. In terms of osmotic pressure, remember, osmosis doesn't care what the molecule is. It only cares about what the concentration of it is, right? How many units there are. So like when we compare plasma, interstitial fluid, and intracellular fluid, the total osmotic pressure, if you look all the way down at the bottom, is almost the same across the board. The plasma has a little higher. That's our plasma oncotic pressure. It helps to keep fluid in the vessels where it belongs. But what makes up that osmolarity varies from interstitial to intracellular to plasma. Sodium and potassium, I definitely want you to compare those two lines. Calcium, that's more of an inside versus an outside. And then notice, let's see, where's the protein? So in our, glucose and protein are also significantly different across the different compartments. The numbers are not important here, okay? Like, I don't want you to memorize these numbers. That would be a waste of neurons, in my opinion. But I do want you to just see how what makes up the osmotic pressure is different across the compartments, okay? I've highlighted one little bit down there, and that is that the normal osmolarity of the plasma is right around 300, okay? That's a value, you know, worth putting in your pocket, so to speak, because when you are asked about osmolarity, that is the assumed normal. So I need to introduce two words, hypertonic, well, three words, hypertonic, isotonic, and hypotonic. When we talk about tonicity, what we're talking about is osmolarity, or osmolality, if you want to get technical about it, but either one. So isotonic means same osmolarity. So for example, normal saline, 0.9% normal saline, is isotonic with plasma. In other words, it has enough sodium chloride dissolved in it that its osmolarity is about 300. Now, the reason that we see that the reason we call it normal saline is because it has that 300, right? It has normal osmolarity, right? And the concentration is 0.9%. Now, what that percent means, it's grams per deciliter. So it's 0.9 grams per deciliter. Gives you 300 milliosmoles per liter. Now, who cares? Why do we care about that? Why are we always reaching for normal saline when we want to give patients additional fluid volume? Because if we give them a hypertonic solution, in other words, a solution that has greater than 300 milliosmoles per liter, we're going to drive free water to move around, right? So if your patient is normal at 300 and I give them, say, 3% normal saline, in other words, saline that is 3 times as concentrated as normal, well, what will happen? Their own water will have a tendency to move toward that solution you just gave them, right? Which is not always what we want. In fact, it's almost never what we want, right? So that's hypertonic, a solution that is higher in osmolarity. Hypotonic, that's the opposite. So that's, we'll say, half normal saline. If we were to give a patient a bolus of half normal saline, we would be essentially giving them more water than solute, and that water in the solution we give them is going to have a tendency to work its way into cells. Okay, so tonicity, the osmolarity of the fluid that we give the patient, determines where the water is going to go. Okay, now to give you a sort of visual on that, we have our normal cell at 300 up in the corner. Isotonic, hypertonic, hypotonic. That's the solution in the beaker that we're going to put the cell in. Okay, so we take our 300 and we put it in isotonic solution. Well, you'll notice the cell here and here are about the same size because the osmolarity inside and outside are approximately equal. So we have very little water moving. However, if we take a hypertonic solution, we see that the cell shrinks. Another way to describe cells shrinking is that the intracellular fluid volume goes down. Okay, fancy way of saying cells shrink. In hypotonic, okay, we have cells expand. In other words, another way of putting that is water tends to move into cells. The intracellular fluid volume increases. Okay, so we had a test question that was just about the osmolarity. This is adding the tonicity component to that. Okay, but similar ideas. All right, so we talked yesterday about the fact that when we put fluid into the body, we tend to put it into the plasma space, right? But the plasma space is in communication with the extracellular fluid space and the intracellular fluid space. So we can think of it as two spaces. Fluid inside of cells, ICF, intracellular fluid, fluid outside of cells, which includes the plasma, right? That's extracellular fluid. Okay, so in our different, depending on what tonicity of fluid we give, where that fluid ends up changes. Okay, so let's look at example A first. In example A, we start, this is our normal, right? So we have about 2/3 intracellular, 1/3 extracellular. We're going to add isotonic normal saline, okay? Now, where will that end up? That fluid is going to expand the extracellular fluid compartment. Why? Because it's not going to trigger water moving into or out of cells. So where is that extra water with salt going to go? It's going to stay in the extracellular fluid compartment. This is why we use normal saline to expand plasma volume. Because every little drop of normal saline that we give pretty much stays in the extracellular fluid, which is where we want it in a patient who doesn't have dehydration or an electrolyte abnormality of some kind. Now, we have the other two cases too. In C, that one down in the corner, now we're adding a hypotonic solution. So the clinical example of this, half normal saline, all right, which is 0.45% grams per deciliter, right? So if we give hypotonic saline to the patient, what we see is that water doesn't all stay put. Some of that water moves towards the intracellular fluid space. So we do get an increase in extracellular fluid, but we actually get a bigger increase in intracellular fluid. This is sometimes exactly what we want. So imagine you have a 3-year-old who's had diarrhea for 4 days. Okay, they're dehydrated. Where is their fluid deficit? Is it in the plasma or the cells? Well, after 3 or 4 days, the cells themselves are going to be short of fluid, right? So we give hypotonic fluid when we want to expand the water that's present inside of cells, right? So that's our example C. In example B, we see the opposite issue. If we give hypertonic solution, this is our 3% normal saline, or a mannitol solution, you may have seen that hanging by the bedside if you've done work at the bedside. Those are both hypertonic. And here we're going to have a decrease in intracellular fluid volume. Cells are going to shrink, right? And where will that water go? It will expand the extracellular fluid space. Clinically, B here is a rarer thing that we would do. The only example I think we see in regular real life is when we have head trauma, okay? When you have a brain that's been whacked about, say in a car accident, all right, it tends to swell like every other thing in the body tends to swell when it's been injured, right? Only in the brain, we're in this rigid container, so we have a swelling problem. If we give hypertonic solutions, we can shrink the swelling cells of the brain and reduce intracranial pressure. You see that? Again, remember the clinical examples are not details for you to know right now. They're just examples of how we use this. Okay, so if we add hypertonic saline, we get the total osmolarity will increase, and the volume increases more for the extracellular fluid than the intracellular fluid. So essentially, we make cells shrink. This is usually a bad thing, right? Cells shrinking causes them to pull away from their neighbors, and when they pull away, the connections are lost, and you end up with disease. But sometimes it's something we have to do. Okay, so tonicity and where that fluid ends up. Now, I have to talk to you a little bit about hyponatremia and hypernatremia. A very, very, very common blood test that we look for in patients is their sodium level, right? And it's useful, but it doesn't always tell you what you think. And I've seen many students over the years make mistakes about this, so I start introducing it now. We'll end up talking about it more later. But hyponatremia, so you get the lab value, and the sodium is below the normal range. Okay, you have hyponatremia. Now, because it says sodium on that line, that's where your young provider brain is thinking, oh, it's a sodium problem because that's what it says on the lab. No, most of the time, hyponatremia is a problem with too much water. All right, do you see how you can have that same difference? If you have X amount of sodium and you dump a bunch of free water in, your sodium level is going to go down, even though you haven't taken any sodium away. You see? Hypernatremia, high sodium, increased osmolarity. It could be a sodium excess. Let's say you had a patient who was unable to drink for whatever reason. All right, so they're becoming more and more, their sodium's getting higher. But much, much, much more common is a water deficit. So after a diarrheal illness, for example, patients' sodiums tend to be high, 150, let's say. It's not because they have extra salt in their body. It's that they don't have enough water. They lost a bunch of free water. So most commonly, sodium, that sodium line in the lab, tells us about the fluid status of the patient, not their sodium status. Okay? And I'm using the sodium level as a kind of surrogate for osmolarity, because in the extracellular fluid space, sodium is the biggest player in osmolarity, right? So as sodium changes, it's reflecting the total osmolarity of the body. All right, more on that topic later, but we start talking about it now. Okay, so we can essentially have 4 states, all right? Hyponatremia, hypernatremia, and then too much fluid or not enough fluid, right? So if you take all 4 possibilities, here's what we end up with. Hyponatremia with dehydration, that's very rare. You can even put that in your notes, very rare, because usually dehydration falls into the hypernatremia category. So where would we get this? We're only going to see hyponatremic dehydration when both the sodium level and the extracellular fluid volume are both low, okay, which is uncommon. Hyponatremia with overhydration, much more common. So when you see a low sodium level, first thing you should think, fluid overload, okay? Why? It could be a central effect. Antidiuretic hormone causes us to retain fluid, all right? So if you're excreting antidiuretic hormone and don't need to be, let's say you have one of those paraneoplastic syndromes that we talked about in MedPath, right? Well, you're going to hold on to fluid and your sodium level is going to tend to fall. So like the bronchogenic tumors, that's the paraneoplastic syndrome. SIADH is syndrome of inappropriate ADH secretion. You can get that from a good knock on the head. So let's say you had a car accident, flung your head about. Days later, you can end up with antidiuretic hormone being released for no reason. So you're holding on to all that fluid, even though you have plenty of fluid intake, right? So you're essentially diluting your blood all the time. So hyponatremia, the most common cause of that is overhydration. So that's the big one. Hypernatremia dehydration. This is anything that causes a loss of free water. Okay, so this could be diarrhea, vomiting. This could be fever, right? Because when you have a fever, your insensible losses go up. Most of the insensible loss is free water. So this could be trapped in the desert, right? So no access to water or reduced access to water. So you become hypernatremic, not because you have too much salt, but because you have not enough water, right? And then hypernatremia with overhydration, again, hugely rare, kind of like the first one, hyponatremia with dehydration. You can get it, but you're going to be into specific endocrine abnormalities at this point, right? Essentially what you have is a problem with aldosterone, which we'll talk more about after we get to talking about aldosterone. So our 4 possibilities for hypo and hypernatremia. All right, so this talk is about body fluids and compartments. So one of the things we need to talk about is extracellular edema. How do you end up with extra fluid in between your cells? So increased extracellular and interstitial fluid. Okay, One of these can be increased capillary pressure. And I say think about it because we've already kind of talked about this, the Starling forces, remember? If I increase the capillary pressure, I'm going to push more water out into the interstitial space, remember? All right, and your lymphatic system can only drain so much. So if you exceed your lymphatic drainage, you will end up with edema in that area of increased capillary pressure. One of the places we see this is in the lower extremities in somebody with heart failure, okay? Their venous pressures get high, so they leak fluid into their legs. They have big swollen ankles, right? You see this same thing in pregnancy, where you have big swollen ankles because of increased capillary pressure because it's hard to get blood past the baby back to the heart. So that's one cause. Another, excessive kidney retention of salt and water. Okay, so this is a kidney disorder. So your kidney, instead of excreting salt and water, which is what you should be if you have edema, you're holding on to it. So acute or chronic kidney failure can do this. Aldosterone excess can do this. So you could have an adrenal tumor, for example, that does this. High venous pressure and venous constriction causes extracellular edema. Incidentally, that high venous pressure also causes increased capillary pressure. So we're into heart failure. Venous obstruction, I say positional. We are always obstructing veins when we are not standing straight up or lying down, okay? So like right now, you're sitting on some of your big veins. So that venous obstruction can be positional. Failure of the venous pumps, remember that we have our skeletal muscle pump. So if we have paralysis from some disease or simply immobilization, like you're on a long plane trip, for example, you will have increased venous pressure, increased edema. Valve failure. We have lots and lots of venous valves. They do fail, though. That cause varicose veins when they fail, all right? If you have a lot of venous pressure over a long time, you end up with lots of valves that fail, and therefore you have increased dependent edema and increased extracellular fluid. Anything that decreases arteriolar resistance has a tendency to increase extracellular fluid as well, because you get more blood flowing through the capillary beds. More blood flow through the capillaries means more fluid into the extracellular space, right? So we get that as well. How can you get that? Heat stroke is one. When we're hot, we vasodilate. If you vasodilate enough, you'll give yourself edema, okay? Insufficient sympathetic nervous system outflow. Let's say you've got a spinal cord tumor, or you've had damage to your sympathetic nervous system from surgery or an accident. And then, of course, vasodilator drugs. One of the ways we treat hypertension is with vasodilation. So like calcium channel blockers, for example, cause an increase in vasodilation, and they cause edema, particularly dependent edema. So another example of how medicines can make trouble. Other causes of extracellular edema, anything that decreases your plasma oncotic pressure. So a decrease in plasma proteins. This could be loss of those proteins through the urine. We call that nephrotic syndrome. You could be losing protein because your skin is broken, right? So you've got a big wound, or even worse, a burn. Patients with extensive burns lose a ton of protein and can have a tendency to become edematous all over their body because of the loss of oncotic pressure. And then failure to produce the proteins in the first place. When your liver goes bad, as in the end of hepatitis or end of cirrhosis or end of congenital abnormality, you get a reduction in plasma proteins, reduction in oncotic pressure, and therefore swelling. You see how the Starling forces play a role here, right? They're determining that in the end. Another place you can get failure to produce proteins is in protein malnutrition. Kwashiorkor, for example, will cause massive edema, particularly in the belly, right? So And so protein is the biggest one. Just plain calorie malnutrition will eventually lead to protein malnutrition because without sufficient calories, you can't make the proteins that you need to make. So that's the whole decreased plasma protein category. Anything that increases capillary permeability will lead to extracellular edema. Immune reactions are the big one here. Histamine is something we produce that ends up increasing capillary permeability and leading to edema. This is kind of the point of it. You know, the body intends to make swelling around a damaged area. It makes more space for the immune system to do its repair work, right? Toxins can increase capillary permeability, particularly certain bacterial toxins. We call them endotoxins. The gram-negatives are very good at this. Bacterial infections for that reason. Vitamin deficiency like vitamin C increases capillary permeability. Prolonged ischemia, and then burns again. Burns play havoc with our fluid management system because without the skin, there's no container to hold fluid, protein, and electrolytes in. So all of those can result in edema. I think there's one more, yeah. And then on the other side, blockage of lymphatic return. Remember, normally there's always a little more fluid that comes out of the capillaries than goes back in. So we have a net fluid outflow into the tissues. If that lymphatic fluid, if that lymph doesn't end up back in the circulation, well, you'll end up with extracellular edema. So how do you get a blockage of lymph? Cancer will do this. If you have a tumor in an area of lymphatic flow, it'll block it. Infections will do that. Lymph nodes can get infected and clogged, right? And therefore, less lymph passes through. Surgery, if we disrupt the lymphatic vessels, which is a side effect of any surgery technically, but we definitely see it in the orthopedic surgeries. Stasis, in other words, the patient's been inactive for a period of time. Remember, the lymph system has no pump. The only pump that moves lymph around is skeletal muscle activity, right? So if you're on a vent, paralyzed in the ICU, you don't have any skeletal muscle activity. So you'll end up with extracellular edema from lymphatic stasis. And then congenital absence or abnormality. There are lots of things that disrupt the lymphatic system. And if you want to see examples of how poor lymphatic drainage can create swelling, look up elephantiasis on Google and look at pictures. You'll see great big huge arms and legs. That's all lymph fluid that didn't get back into the circulation. I think somebody's out there, but okay. Let's see what we got. I did review these earlier, even changed an answer. Uh-oh, right? Okay. 1 liter of 3% saline, in other words, hypertonic, given to an otherwise normal patient, what will happen? Here, I'll move my... Yeah, very good. Your intracellular fluid volume will decrease. Cells will shrink. It isn't the yellow one because you are still giving the patient water, right? So you're adding to the total body water. You're just moving it out of cells, which is probably not what you want to do unless you're trying to reduce swelling somewhere. All right. 500 mLs of free water is given to a patient. What will happen to the sodium level? Okay. So if we give free water, sodium will go down. Right? We're messing with the denominator here. Remember, we talk about concentration as something per liter or per ml, right? In sodium, it's milliequivalents. So if I give you more water, I will make your milliequivalents per liter less, because I haven't given you salt, I've just given you water. So I've increased the denominator without changing the numerator. This is one of those topics that's really important out of this lesson, all right, that when we give water, we reduce our values of things like sodium and potassium. It's dilution, okay, is what we're doing. And it goes along with, when your sodium level is high, you don't have excess sodium. You have not enough water. It's the same thing as this in reverse, okay? All right. There's never a good place to put that thing. Okay, a soldier is rescued from the deep desert. Her sodium concentration is 150, which is not true. Oh man, I changed it and it didn't save it. All right, let's. Grr. This is the one I changed. Yeah, okay. So her sodium concentration is 150. So just knowing that, you plucked her out of the desert, her sodium concentration is 150. Is she dry or wet? She's dry because she came out of the desert. Does she have too much sodium or not enough sodium? Or who knows? Who knows technically, but her sodium's probably fine. Okay, yes, she would have lost a little bit extra. So let's go through each one. Would her blood pressure be elevated if she's dry? No, because her plasma volume is down, right? So her blood pressure is going to have a tendency to be low because her venous return, EDV, stroke volume is low, right? Her renal salt excretion, will it be decreased? In other words, will she be holding on to salt? She will, because that's how we hold on to water, right? You got to hold on to salt in order to hold on to water. And admittedly, this is a screwed up question. That's why I tried to fix it earlier, but it didn't save it. All right, the patient is salt overloaded. Is that true? Unless she made some really bad choices in the desert, no. Okay. Soldier, I didn't even spell that right. A solider. She's a solider. Maybe that's her problem. But no, she would not be salt overloaded unless she was somehow taking in excess salt, and she should know better if that was the case. And is the patient water overloaded? No, of course not, right? Because she just came out of the desert. So trickier than typical question, all right? And made more difficult by the fact that I think it's one of these is totally wrong because of the way it's worded. But anyway, onward. Okay. Patient's running a fever of 103 and is tachypnic. Which of these is true? Insensible, very good, most of you got that. Insensible losses are increased. Right, increased. Why? Fever, having a higher temperature, does a number of things. Number one, it causes vasodilation to the skin, so your losses from the skin increase. Another is it increases your metabolism, so you burn through water faster, all right? Tachypnea increases your water losses because every breath you take, you lose some water. If you take more breaths, you lose more water. And I have this in the Kahoot set on purpose because particularly in children, all right, children with fever and respiratory distress blow through water like nobody's business, okay? Their insensible losses are significantly higher. So when we treat these patients, always with kids, you got to watch their fluid balance, but kids with respiratory distress and fever, doubly so. All right, last one. A patient has a disorder which blocks effects of antidiuretic hormone. What would the sodium concentration be? Antidiuretic hormone makes you hold on to water. Yeah, okay, well, you had it narrowed down to up or down. All right, so if ADH is not working, the way you notice this in the patient, okay, is if ADH is absent, they make oodles and oodles of really dilute urine. Okay, in other words, their water loss is very high. So if your water loss is very high, your sodium is going to end up elevating because you're taking the water away from the denominator. See? So in a patient, we call this syndrome. No, this isn't SIADH. This would be, blockade of ADH. You would have increasing sodium concentration while you're peeing out oodles of water.
Wait, I have a question.
Yeah.
So you're peeing a lot, right?
Correct.
So, but the sodium's not going with the water, like leaving?
Very good question. All right, so ADH works on water, not salt. It's one of the few things that does. Can I put a pin in that one?
Yeah.
Okay. We are going to talk a lot about why that's the case, but you are thinking it through. Water does typically follow salt. But if you have a blockade of ADH, you're basically peeing out free water. Not water with salt, just water. So your sodium concentration goes up and up. Can be fatal, in fact. Because remember that osmolarity affects the cell size all over the body. So anytime you have a patient with a high sodium, they have a high osmolarity, and that means that their cells are having a tendency to be hyperosmolar. So you have to be careful about how you add fluid because they can puff back up in a heartbeat and you can end up with seizures. But more on that later.